Hello, it's Sarah here. I am doing my presentation on a 66-year-old female with a history of hypertension, COPD, depression, and tobacco use in the form of cigarette smoking, who presents with complaints of dizziness. In December of 2018, she was referred to cardiology and underwent a carotid duplex, which diagnosed her with bilateral carotid artery stenosis of what I believe was about 50%. She reported having these episodes of dizziness back in 2018 before she went to see cardiology. And now, in the last 2 months, they have only been increasing in frequency, and now they are occurring daily, anywhere from 1 to 3 times a day. These episodes of dizziness occur with position changes when she goes from either lying or sitting to standing up. She reports also sometimes feeling a racing heartbeat and feeling off balance when these episodes occur, but denies that she has ever fallen or lost consciousness. She reports closing her eyes and using deep breathing techniques in order to help the episodes pass. And she denies any dizziness with sudden head movements or when she's lying or sitting down. She denies vision loss, hearing loss, nausea, vomiting, personal or family history of seizures, any head trauma, skipping meals, the alcohol use, any new medication or supplements, and also denies any illicit drug use. She does report some occasional marijuana use 1 or 2 times a month. On exam, her neuro exam was normal for equal strength bilaterally and her upper and lower extremities. Cranial nerve testing was normal. She had no paralysis or numbness or tingling. She did have a limping gait due to an accidental right foot injury the previous day before she was in clinic. She reportedly accidentally kicked the corner of a piece of furniture, and her right foot showed some bruising and +2 edema to the dorsal aspect of her 2nd to 5th metatarsals and toes. But it had brisk cap refill, was warm in color, and she was able to bear weight and move all of her joints. Her cardiovascular exam was normal. She had a normal rate and rhythm, no murmurs, rubs, or gallops, no carotid bruits were heard. We did do an orthostatic blood pressure exam, which was normal, negative for any orthostatic hypotension, and her vital signs were normal. Also did a 12-lead EKG, which was also normal for sinus rhythm. On the differential diagnosis list, first I chose cerebral ischemia due to her known carotid artery stenosis and potentially some and she is now potentially showing signs of worsening cerebrovascular ischemia. Also included on the differential list was orthostatic hypotension and benign paroxysmal positional vertigo. This patient has known cardiovascular risk factors of hypertension, an elevated BMI, with also a 22-pound weight gain in the last 10 months, and a history of tobacco use, who has just quit smoking in the last 2 months. I'm unsure of how many years she was a smoker. As well as a known diagnosis of carotid artery stenosis bilaterally. Based on the subjective findings from talking with this patient, that these dizziness episodes are the same in presentation that they've always been, but are now increasing in frequency. That further supported a need for further evaluation of her vasculature to rule out any worsening cerebral ischemia. In her professional care of the patient, a medical assistant was part of this visit and helped to bring the patient to the exam room and perform initial intake of vital signs, as well as the orthostatic blood pressure readings and the 12-lead EKG in order to help myself and my preceptor with the flow of the visit. Also, a referral to a specialist was made as we referred her to cardiovascular for further workup. And while we didn't communicate directly with the specialist, that is something we had to consider while writing the note for this patient to make sure that communication was sufficient within the note for that specialist. So the article that I chose is a level 7 type of evidence that basically just talked about dizziness and the different differential diagnoses to consider for dizziness, and talked about an appropriate physical exam and appropriate questions to ask with the interview for the patient. And the 3 main take-home points that I took are just that asking detailed information surrounding the timing and triggers for dizziness is the most important in obtaining information during the interview with the patient. Also, the head impulse and Dix-Hallpike maneuver physical exam tests are important to include in a physical exam for this patient, and those are not things that I did assess for in the visit. Also, a thorough neurovascular, cardiovascular exam is important. And also, last point being central abnormalities cause approximately 25% of dizziness in patients, of which the cause of vertebrobasilar ischemia is included. And vertigo is the initial symptom in about half of patients who have vertebrobasilar ischemia. So I thought that was interesting, and that's all I've got. Thank you.